Am I audible? Yes, sir. Okay. Okay. So, good afternoon, everyone. On behalf of Department of Physiotherapy, CRC Kozhikode, we welcome you all to this national webinar on behavioral skills in treating low back pain. This is the first national level webinar organized by the Physiotherapy Department. We are really overwhelmed by the immense support received from you all. We received nearly 600 registrations for this event. The participants, as well as from abroad. I would like to discuss a few things about the Institute. Composite Regional Center for Skill Development, Rehabilitation and Empowerment of Persons with Disabilities, Kozhikode, is a central government institute under Ministry of Social Justice and Empowerment, Government of India. We have various departments including audiology, speech language pathology, occupational therapy, special education, and physiotherapy. Also has units of social work and placement, prosthetics and orthotics, as well as KV is leading the physiotherapy department with the support of B. Marimuthu and Fatima Sumaya. Without further delay, I would like to invite our beloved, who is the great inspirer for us in organizing large events like this, for inaugurating this webinar. Over to you, Roshan sir.
Okay. Good afternoon, everybody. At the outset, I welcome you all for this national level webinar organized by the Physiotherapy Department of CRC Kozhikode. And Mr. Binoy has given a brief intro regarding what CRC is. We all know that we are facing such an unprecedented situation which we have never even dreamt of in our life. And there are many new normals for us, and this sort of webinars is one among such a new normal for each and every one of us. And as a saying goes, there is an opportunity in every challenge, and this is one such opportunity wherein we have a facility now to attend quality classes, webinars from experts and exponents all across the world. This is something new for majority of us. And I don't want to steal away much of your valid time just with some sharing some thoughts, because we are all waiting for an expert talk in a very interesting topic. So I'm glad that we are having such an exponent details will be given by Marimuthu, so I'm not going into the details. But he's a multifaceted personality, a renowned person in his field, and we are happy that we are having him as our resource person now. And I also take this opportunity to congratulate physiotherapy department led by Mr. Binoy Matthew and ably supported by Marimuthu and Fatima Sumaya. And the organizing has come out very well, and it's nice to know that there are 600 plus registrations for this, and I hope this webinar will be of use to all professionals in the field. So officially I declare this webinar inaugurated, and I heartily welcome Mr. Bibin for his presentation. Prior to that, I request Marimuthu to give further details regarding our learned resource person. Thank you.
Okay, thank you. Hand over to Marimuthu to introduce the resource person of our national physiotherapy webinar.
Hello. Hello and welcome you all. It's a great pleasure for me to introduce our speaker, Mr. Bibin Prasannan sir. He has completed his bachelor's and master's in physiotherapy from Manipal University. His specialization is orthopedics and hand rehabilitation. After post-graduation, during his brief stint for 3 years at Medical Trust Hospital, he worked as lecturer and was part of medical team from Medical Trust, which managed so many sporting events of state and national repute, which includes Indian Premier League cricket and Ranji Trophy cricket matches. After finishing his stint at Medical Trust, he went to establish his clinical startup called as Santwana Physiotherapy. He is keenly interested in professional upgradation program and has completed over 30 MOOC certifications from Future Learn. Some of the certifications that he has been conferred upon include American College of Sports Medicine, Certified Personal Fitness Trainer Licensure, Basic Life Support from American Heart Association, NESTA as Certified Core Conditioning Specialist, Figure and Physique Trainer, Sleep Science Coach. Also got Participation Certificate in Exercise in Medicine in Australia, and COVID Stress Management Certification. Also an accredited doping advisor, a certified e-bug educator, and a certified basic and advanced pranic healing. He is actively involved in educational programs and CREs of Composite Regional Center for past 2 years, and he is an active blogger as well as a writer. We would like to hear a lot from you, sir. We welcome you. Before handing over to the presenter, we would like to remind all participants to please mute your mic and turn off your video during the sessions. You can post your queries at the chat box at the end of the session. And also don't forget to fill out the feedback form that will be shared in the chat box at the end of the webinar to qualify for the certificates. And now I'm handing over to the presenter.
Hello, I sincerely thank CRC for giving me an opportunity to address such a wide audience on a relatively new topic called as behavioral skills in treating low back pain. It's a relatively, even though about this topic we had heard a lot of things before, this is a relatively new topic in this domain, and recently we have been emphasizing more and more regarding the psychological parameters of the patient. So let's straight away go to the topic: behavioral skills in treating low back pain. So can you just have the slides, please?
So can you see the slides?
Yeah, I'm not able to see here.
Participants, please pin the Composite Regional Center.
Yeah, now I can see. Thank you. So the topic of today's discussion is behavioral skills in low back pain. What we basically mean by behavioral skills, it's not about the basic techniques that we are speaking. We are the thinking habits in the patient's mind that can directly or indirectly impact our rehabilitation program. In most of our clinical scenarios, we might have dealt with at least one or two patients in such a way that we might have felt that whatever techniques that we had given to the patient is perfect. There was no fault in our assessment and rehabilitation, but still regarding the outcome of treatment. So in such scenario, we would like to deeply interfere in the thinking dynamics. We would like to break the unhealthy thinking patterns of the patient. So this behavioral skills is basically aimed at breaking unhealthy thinking patterns and analyzing the patient's thought by himself in order to achieve a better treatment success in our rehabilitation program regarding low back pain. Next slide, please. This presentation mainly aims to incorporate the behavioral skills program in our basic clinical setting. We are just trying to analyze how a patient's thinking pattern works whenever he is suffering from pain. So we'll be dealing with a cognitive behavioral approach, and we'll be dealing with how we can use the skills in our day-to-day clinical practice, and how we can modify our skills depending upon different types of patient nature. Next slide, please. As we all know, pain is a very valuable feedback that our body gets. Whenever a person is in pain, that shows that there is something that is abnormal, that is deviated from the normal. So pain causes differently, think differently, and behave differently. Why this difference occurs? Because this is integral for tissue healing. If a person is not feeling a variation in sensation, he may not be aware of the painful stimulus that he's encountering. So that is perfectly normal. But what happens, even if the painful stimulus is removed from the body, in a long term, if the pain perception persists in our human brain, that becomes new abnormal thing, because the painful stimulus is absent, still our brain is perceiving that pain is present. So if the abnormal behavioral pattern persists even after the painful stimulus, or the painful stimulus is gone from our body, that is an abnormal thing. So sometimes what happens, whatever problem we are having in our body, that is solved, but still the brain is recognizing that a threat is there, a painful stimulus is there, even after the painful stimulus is healed or withdrawn from the body. So we need to retrain our brain in such scenario. Next slide, please. So then the question comes, why such a pain persists in our human body? Sensitivity. In a simple terms, what do we mean by sensitivity? Sometimes we tell people are sensitive. Why? Because even a small joke will provoke them, right? some of your friends might be like that. Even if we crack a small joke, the person will really become hot-blooded. So same way, we have got receptors of pain in our nervous system. So what happens in the initial stage, the sensitivity of the receptors that carry the pain stimulus increases. That is a new normal, because whenever a pain sensation is there, the sensitizers in the human body, they get activated a lot. But what happens even after the painful stimulus, if the brain is not retrained that the stimulus is gone, we have to get back to the normal, this sensitivity persists in our body. So once the sensitivity persists, that results in an abnormal pain perception. Means the pain stimulus is gone. Still, due to the excessive sensitivity of the receptors, the person perceives that the painful stimulus is still there. Memory. Our brain has a memory to recollect the painful experience. Same, we as human beings, we tend to recollect the people who had hurt us a lot, whom we feel uncomfortable with. So in such case, what happens that whenever we come in contact with such person, knowingly or unknowingly, we feel uncomfortable. So our brain has a working memory, and whenever even though we are not in direct contact with the painful stimulus, even though the situation that leads to the painful stimulus arises, our working memory alerts us and it results in the painful perception. Representation. Our brain has something called as motor homunculus, where all our body organs are represented in a schematic manner. So when a person is having severe pain, this schematic pattern can be altered. So the painful part will occupy the whole of the nervous system, overtaking the other normal parts. Suppose a person is having back pain, and this pain will result in excessive irritation to the body part. Even though the pain is happening in a portion distal to the body part, a person will be having pain in the back. Suppose a person is having a painful irritation in the hand, he will be feeling the pain in your back. So that's what we mean by representation, altered representation. Emotion. For a person who is excessively depressive in nature, there are greater chances that the pain may persist for a longer period of time. Next slide, please. So normally we believe that pain is protective. Okay, till recently, 5 years back, even though we as physiotherapists, we used our pain guidance parameters. Whenever a person is having pain, we used to guide our activities in such a way that the pain stimulus is very minimal. But recently, the researchers have proved that the amount of pain that we experience, it cannot be directly correlated to the amount of tissue damage that we are encountering. For example, if we check the 90% MRI of normal person, they will be having severe disc herniations, which will be non-symptomatic. But when the pain arises, that disc herniation becomes a problem. So two scenarios can happen. Even with severe of internal tissue trauma, person may not experience pain, or even with minimal tissue trauma, person may experience severe pain. But one thing is there. However, the pain pattern may persist. If you want the pain sensation to hurt you or not, that is entirely dependent upon your human brain. So the human brain is the part that decides whether you want a stimulus to be painful or not. Like the famous saying, like, no one can hurt you or reject you until you allow them to. So it's a brain that decides whether a stimulus is painful or not. So we are mainly concentrating on how to retrain the brain in such a way that a person can carry on his day-to-day activities with minimum hindrance from the painful stimulus. Next slide, please. Okay, so we have told that the pain is absolutely normal in the initial phases, but what happens? Chronic pain. Chronic pain in the sense we mean the pain that persists for longer than 3 months. So in case of chronic pain, the signals that the brain receives may not directly reflect the state of your tissues. Like it may not directly reflect to the pathology. Sometimes a person may have a very minimal injury and brain may perceive that the pain is excess in nature. So in such situation, we need to retrain our brain and pain system. Next slide, please. So we are going to discuss about cognitive behavioral model here. What we mean by cognition. Cognition is basically our emotion, our thinking process. So see, there's something called as event. Event may be good or bad. Almost all of us might have faced some sort of traumatic situations in our life. So, but what makes the difference? But what makes the difference is how we are trying to interpret it. Like a person might have encountered failure in his life. First person may get depressed, and the other person may learn lessons from it and try to get stronger in his next life ventures. Same way, a simple back pain stimulus can give rise to multiple thoughts in the patient's mind. So that's an event. It depends upon how a person interprets the event, and this analysis will lead to different type of emotion in different persons. And what is of great significance is we want to check whether this emotion is useful for us in rehabilitation or not useful. If this emotional parameters are interfering in the rehabilitation, then we need to break it and we need to reorganize in such a way that the patient can cope effectively in our rehabilitation program. Next slide, please. Okay, we are just talking about event and emotion. See, if a person is having back pain, so the most common emotion that he encounter will be sadness. Okay, so when a person is sad, in two ways person can think. One way the person may think that uh, if I am having pain, okay, I can get an expert consultation and I'll find solution for it. So the person is tackling the pain in an effective manner. The second person may think, oh, this pain is too much for me. I'm going to be in bed forever. No one is going to help me. And this pattern has set in his mind. So before coming for a therapy session, he has already become mentally disabled. So if we are not addressing this mental disablement as a component in our therapy session, our rehabilitation program may not find the usual effectiveness that we are aiming to bring in the clinical setup. Next slide, please. Okay, so I told that if a person is having pain, a different variation of different thoughts can come in his mind. First one, a person will think, oh, I can't believe that it has happened. So the main emotion will be anger. Second person is, I won't be able to work and I'll lose my job. He's worried. Third, I had this problem before. I know how to manage it. So this person is nervous but positive. So once when we are taking the history, the way by which patient presents us the back pain symptom can give a clue regarding whether the emotion that is happening in the person is anger, worry, or nervousness. So by the way which the person frames his statements, we can convert it into the possible emotion that the person is having. Next slide, please. This is a cognitive behavioral model. What is cognitive behavioral model? We have been talking this in the previous slides also. There is an event that is happening in a person's life. And when this event is happening, the person has some thoughts in his mind. And these thoughts will make the person to do certain action. And this action will lead to a behavior. So in this case, our behavior will be concentrated towards the exercise program in our rehabilitation setup. To make things simple, suppose some of you cricket might be here. No one can forget the 1999 match between South Africa and Australia. So what happened? This image of Herschel Gibbs has been very famous. So he was trying to take the catch of Steve Waugh. So what was, let us consider the cognitive behavioral model in case of Herschel Gibbs. So what was the event? Event was he was attempting to take a catch. So what might have been going through Herschel Gibbs' mind? I have taken this catch. So what was his feeling? If you check the video clip, you can find that before taking the catch completely, he has been trying to drop it. So he was not able to translate his thought into an effective emotion which could have led to a proper behavior for his team. So that was the first fault that Herschel Gibbs had, that he was not able to properly register that the catch has been taken properly. Same way in the final overs where they required 9 runs to win, Damien Fleming was bowling and Lance Klusener hit first 2 balls for 4. So he could correctly translate his thoughts into behavior. And later in an interview, Lance Klusener said that the third run was actually the single that he was going to take was actually not there, because Alan Donald was not such a fast runner and he could not reach the other end. So in the third instance, whatever he wanted to do, he was not able to directly translate it into a possible action. And for the team, it costed them the World Cup match. So that's how we can apply this cognitive behavioral model in our rehabilitation setup, in our day-to-day life, or in any other person's life to find out what is the link that we are trying to address. Next slide, please. Okay, so this we are talking about the patient feeling. When a person is having back pain, the person may feel worried, fearful, anxious. These all emotions are perfectly normal. But what matters as most is the time duration for which these emotions persist in the human brain. While we have to tell the person that the sense of pain is completely normal, but it's abnormal that even after the pain has healed, the person is feeling the same painful stimulus. That is abnormal, and we have to retrain it. So depending upon different type of emotion, we need to retrain the patient's behavioral pattern. Next slide, please. So cognitive behavioral interventions in physiotherapy mainly are directed towards the abnormal behavioral pattern that may interfere with the exercise treatment. So we have to analyze the thinking pattern of the patient, and we have to analyze the behavioral components of the patient, and these two together form cognitive behavioral intervention in our exercise regimen. Next slide, please. So we know the traditional physiotherapy approaches. We follow whether a person is musculoskeletal therapist or a neurological physiotherapist. We follow a problem solution approach. So whenever we are having a problem solution approach, we greatly neglect the mental dynamics of a person. So a physiotherapist commonly performs the role of a posture corrector or a person who is trying to find out links in musculoskeletal or neurological or cardiopulmonary abnormalities. And we rarely try to address that person's mental behavior or mental dynamics can lead to increased pain perception despite of giving best treatment for him. So rather than we using a corrective model, we have to make a patient the authority for his exercise program by giving him various exercise techniques, by giving him an independence to select the technique that he is comfortable with, and by helping him to find out how to progress in minimal pain. So for such a scenario, we need to have a person-centered approach. So rather than using a please fix me model, we have to incorporate a person-centered approach, as we have been emphasizing that a client or patient is central to the rehabilitation concept. Next slide, please. So this lot of psychological factors, like a person might have a traumatic event in their life. A person might have been coping with great sufferings or great pain that had happened in their life, or they might be having certain unhelpful thinking regarding the pain perception and unhelpful working conditions. So all these factors can lead to the magnification of pain stimulus. Next slide, please. So here we are trying to find out what problem each individual is having depending upon the way by which he presents a history, depending upon the way by which he puts his statement of problem. We are trying to analyze whether the person is angry, depressed, and how that emotion will be greatly affecting our rehabilitation. So mainly we are addressing how a person's thought can affect his joint dynamics, how a person's lifestyle can affect his fitness patterns, and how it will in turn affect the rehabilitation. Next slide, please. So till now, like behavioral pattern studies never had such high evidence, but 1 year back, 1.5 years back, Oxford University had conducted a big trial on 701 patients. And these patients, almost all of them had a non-specific low back pain for a 6 or more weeks. So this treatment program were administered considering the viewpoint of different professionals, including physiotherapists. So this initial part of back skill program has been entirely adapted from the Oxford technique, and they had found that apart from the usual rehabilitation technique, if we use a back skill program or a behavioral analysis program, the disability that a person experiences will be often much better, or the rate of improvement will be much better compared to the traditional rehabilitation program. Next slide, please. So this is the statistics that they had derived. So you can see it is mean change in patient disability from baseline. So read the statement carefully. It is not increase in disability, change in disability, like in whatever percentage of improvement that they had reported. So in the traditional care, you can see that after 3 months, around suppose out of 100, 8.9% reported an improvement in their disability pattern. And when we compare that to the back skill program, the disability amount of improvement was around 5% more, the change in disability. So same way, when we do a longer follow-up, it has been found that the back skill program provided a better reduction in the person's disability compared to the traditional back pain programs. Next slide, please. So the best program, it mainly consists of individual patient session and treatment session, and next will be group session or individual session, where we are trying to educate the patient regarding the dynamics of pain and how the pain is perceived and how it can interfere in their day-to-day life. Next slide, please. So we'll be discussing, we'll be talking to the client regarding the diagnosis and how the disease will be progressing, and we'll be setting a goal. And whenever goal setting is there, it's better to emphasize clear-cut goals. And the goal, there should not be a mismatch between patient goal and therapist goal. So a common goal should be derived, which is agreeable to both patient and therapist. And we need to address what are the patient expectations for treatment. It depends upon various individuals. So suppose a person is coming to your clinic with a low back pain, and you have forgot to take the fitness activity the person is having. You have done your treatment to the level, but some person has reported decrease in pain symptoms. Immediately after the next day, the person comes back to you with severe pain, and you take the history. He tells that I am a professional, I am a fitness professional, and I have tried to do squat with 40 kg dumbbells overhead. So what's happening is that the expectation was different. So depending upon the client's activity, his profession, you need to tailor the exercise program which he can carry out at home. Next slide, please. So in the skills session, we'll be talking to the patient regarding what is pain, why the pain persists, and what is the relationship between the activity levels and how exercise can improve the pain. Next slide, please. Some of the skills that we guide the patients to achieve is like how to solve. If a person is having a painful activity, how to solve, and how to find out what is the baseline of a patient, what is the baseline activity that the patient can carry out, how to do relaxation techniques properly, and how to challenge the unhealthy thinking patterns the patient can have, how to deal with increase the pain while doing normal activities, and how to progress minimal pain. So here emphasizing mainly active problem solving. So patient is the main authority in this exercise pattern, and he has full power to modify his exercise with the input of physiotherapists in such a way that it has minimum hindrance in his day-to-day activities. Next slide, please. So normally each session will have the same structure, and after the session we'll give a 10 to 15 minute break for the patient, and the queries of a person will be addressed, and we'll be advising the patient to use the same techniques in his home, and we'll be taking the feedback how the session went through. Next slide, please. So back skill training program is commonly used for non-low back pain for 6 or more weeks. So it's a program commonly aimed for chronic pain, for individuals who are having chronic pain. Okay, next slide, please. So the main concern here is the patient's thinking pattern. As a therapist, we explain to the patient like what exercise that we are planning, what exercise will be useful for them, what is not useful for them. But at the same time, it is equally important to address the patient's thinking dynamics, what patient thinks, whether thinks that this therapy will be of any use to them, because most of the patients might have tried various other techniques, and as a last resort they might have come to the physiotherapist. So in their mind they might not have much belief in this system. So these thinking patterns we should address before starting before understanding the patient perspective. This all thinking patterns should be incorporated in the normal practice. Next slide, please. Okay, so we are trying to interview a patient, and in this thing we have to know that there are 4 important concepts. The patient and therapist are partners in this technique, and we need to accept a person without any professional prejudice, religious prejudice, or political prejudice, because prejudices can arise in different manner. So you have to accept the client as he is. Let us chart out what our deficiency the client is having, and then try to find out what is the best possible treatment that we can deliver within those limitations. Compassion, always behave in a positive way to all the queries that patient is addressing, and always try to put even the negative thoughts in a positive way, in such a way that the patient is not losing hope in your treatment. And evocation means to invite active attention of the patient in your treatment technique. So these are the 4 important components that we are addressing. Next slide, please. Okay, so first thing is empathy. What is empathy? Empathy means knowing difficulty of other person, means or putting yourself in someone else's shoes, as we can say. Like if you put your leg in other person's shoes, then only you will come to know whether the shoes is tight or shoes is loose. So empathy is about uh, knowing the difficulty of other person, thinking about the difficulty of other person, and trying to find a perfect match between the patient's and therapist's shoes. So empathy is addressing the patient's problem. Make the patient aware that you are aware about the patient's problem and you really care about it. So in the initial session, you should let the patient speak, because the way by which the patient speak will give you certain important clues. Some person will be having chronic pain and they will tell, oh, I feel like cutting my hands off. So that much severe is my pain. I feel like cutting my hands off. Some clients will tell, I don't know what I'll do with this pain. I have lost any hope. Sometimes I feel like killing myself. So some of these statements will give you an important clue whether you want to refer this individual to a more suitable professional if he's having severe mental coping maladaptation that you can't directly address. So it's always better whenever you take a history, the patient, if you find that the patient is highly depressive, you need to have a proper medical care and then invite the patient back to the therapy session. Next point, avoid argumentation. You have to understand the fact that the person will have a point in their mind and they would always like another person who support their view. So always try not to directly contradict the patient's view, even though you feel that whatever patient is speaking is wrong. So at least in other way, you try to remodify his arguments in an effective manner. So in the coming slides, we'll learn how to remodify. Roll with resistance. Roll with resistance means what? If you know that the patient is non-cooperative to the regimen, you should spend more time in listening carefully to the client's problem. And you have to find for the links by which you can positively change the thoughts of a client if it is under your direct control. You can invite, develop discrepancy. What does it mean? You can question the client back that what he feels will be the consequence of a particular behavior that you feel may not be helping in the therapy session or may not be helpful in achieving important goal. Self-efficacy. Self-efficacy means you once a patient has correctly learned the technique, you encourage the patient to carry the treatment by their own. Most of the times in our clinical setup, the patient will be having a relief of pain. Our goals might have reached, but patient feel like coming back to you. Why? Because he or she feels that coming to a physiotherapist, surely the pain will be better or the patient will feel better. So that's also a negative thinking pattern. It's a duty of physiotherapists that once you feel the correct rehabilitation time has been utilized, it's better to make the patient self-independent, let the patient carry out his goals in an independent manner rather than continuing with the treatment. Next slide, please. So how the goal should be? The goal should be SMART: specific, measurable, attainable, relevant, time bound. How we will get a specific goal? We will get a specific goal by taking the history of the patient. So patient, we can like what you aim by this therapy session, what you feel that you will be able to do by attending properly to this rehabilitation session. So patient will tell, if the patient is a housewife, she'll be tell, I want to do my household chores without much interference. If it's IT professional, he will tell, I want to sit for a longer period of time without any low back pain. If a student, he'll be telling that I want to attend my class teacher, I want to attend my lecture without a longer period, without pain for a longer period of time. So that's how we identify the goal. Measurable. How we can measure? By checking out the way by which the patient does their day-to-day activity. The day they come to the clinic, and after your rehabilitation session, normally we'll do re-evaluation, right? So that is measurable. How we can measure the normally for back pain, we'll measure by checking the trunk movements, which measure by the way by which patient carries out his day-to-day activities, his squatting technique. Attainable goals, the goals that can be achievable, that can be realistic and manageable. That only. Suppose a person comes with a lean individual comes with you and he's telling, I want to be a fit professional, and my back is paining, I want to be a fit professional. So you have given him all the core strengthening techniques, everything, and at the end you are telling, okay, you are okay, you can finish the therapeutic session. Patient is unhappy. Patient tells that no sir, and he says, this is something that I wanted to attain. Is that possible? It's not possible, because those were the bodies that has been built up by rigorous training techniques for so many years. So let's do something that is attainable, relevant. Like, check out what goal is relevant depending upon the patient's day-to-day activities. A sedentary individual mainly doing household chores, there is no need that he or she should be able to do a planks for 30 to 60 seconds or 1 to 2 minutes. But if the same time, if a person coming to you with back pain is a sports personnel, or he's a person, a manual labor, then you have to think of more dynamic activities, time bound. We would try to minimize the therapy efficacy and independence of the patient depending upon the chronicity of the condition. So our aim should be to achieve all the goals in optimal time period. Next slide, please. So these are some of the exercise techniques that we'll be teaching the patients if he's having a non-specific low back pain technique. It is mainly done to stretch your tight back extensor muscle. This exercise will be telling the person to lie on the back and bring both knees to the chest. Either he can do first technique or second. Sit on a chair, keep the leg apart and bring the both wrists to the floor and repeat. And option 3 is standing. The patient can try to touch the toes. So the person is given choice. Whichever option he can do with minimal pain, he can opt that technique. So that's regarding, first one is regarding back bending, where a person is having a tight back extensors, we are trying to improve the mobility in that segment. Next slide, please. Next is back twist. This commonly we use to improve the lumbopelvic mobility and back stretching exercise. Commonly used is back twist. These are also 3 ways the person is advised to do. In supine lying, the patient can keep both the feet together and then he can bring both the hip and knee joint to flare it outwards. Okay, we can try to, the person is advised to keep the heels together and try to draw both legs in an outward manner. That's the first option that the person can do. Second, person can opt for a supine lying and he can try to bend the knee and rotate it towards the contralateral leg side. If that also patient is feeling uncomfortable, you can modify the exercise by sitting at the edge of the chair and try to trunk. So depending upon these 3 techniques, at least the patient is given choice to select the best possible exercise that he can do with minimal pain. Next slide, please. Back arching exercise. It's mainly to improve the trunk extensors strengthening. So here the person is first given an option to keep both forearms on ground, and then with keeping the head in neutral position, he can arch his back and lift his chest upwards without extending the elbows. So this is the first option. Second option, the same way he can do the exercise by extending the elbow. Third option, he can do the and then extending the spine. So among these three techniques, whichever is less painful, the patient can select. Next slide, please. Next is hamstring stretching. In three positions, we are teaching the patient hamstring stretching. In supine lying position, sitting knee straight. And in the first case, we may not promote much of knee extension. We'll promote a hip flexion, and a person can hold the hand behind the popliteal fossa and try to extend the knee as he can, slowly try to extend. So in the second, sitting, one leg bent, one leg straight, and try to bring the trunk towards the extended leg. Third one is standing, one leg bent, next leg straight, and then trying to kneel the hands forward. So these all are the three variations of the hamstring stretching that we are trying to incorporate. Patient can select whichever technique is less painful for them. Next slide, please. Next is sit to stand. In first one, we are advising the person to lean forward in such a way that the full weight is concentrated and both heels are flat on the ground and with knees slightly bent. The person is told to sit to stand. First person will sit on the chair, then try for not a complete standing, partial standing. In that partial standing posture, the patient, with the help of his fingers, try to get back to the chair and get up. So he's taking a mild finger support in the first technique. Second, without any finger support, patient is wrapping his both shoulders with both hands and then trying to get up and sit down. Third technique is on person can do with outstretched hands, extended elbows, and then try to lower the back and then get up. So it's regarding the sit to stand position. These three variations we are offering. Patient can select the best possible treatment technique that he is comfortable with. Next slide, please. Next is abdominal curls. Abdominal curls, the patient is told in sitting position on a chair leaning back. The person is told to tuck his tummy and then try to bend his trunk in a slow, gradual manner forwards and then backwards without curling the back. So what a person is doing, person is sitting at the edge of the table, he's tucking his tummy and he's just gently trying to tilt the body towards the trunk and away with minimal back movement. So this is the first exercise the patient can adopt. The second exercise is done. Patient is in supine lying with both elbows extended, and in supine lying both elbows extended, and what person is doing, he's tightening his tummy muscle and he will gently lean forward and lean back. In the third, the elbow is bent and person will do the same thing. He'll tuck the tummy and will try to do a mild trunk movements towards and away from the body with without exaggerating the spinal curvature. That's the main thing. So in all these exercise techniques, we'll tell the person to try to do the minimal movement without exaggerating the lumbar curvature, or we'll tell him to avoid jerky movements. Next slide, please. Next is bridging technique. Three techniques we are advising the patient. First one is tightening the tummy muscles, keep the feet forward, and in this technique, person is just allowed to lift the buttocks in a very minimal manner. So in the first technique, the lifting of buttocks will be very minimal. In the second technique, we'll be telling the person to lift the buttocks. Third technique, single leg bridging, opposite leg extended, and lift the buttocks. So patient can progress through each of these diseases as his pain tolerance limit improves. Next slide, please. So the summary of the session was to understand the patient's problem, to discuss the patient goals, and to discuss a program in such a way that the patient can only progress at home. We are trying to make patient the authority of treatment program and with the input from our side. So the main aim is to understand the patient problem and help the patient to facilitate an exercise program at home. Next slide, please. So how we can improve this in our clinical skills? So we are questioning the patient, some parameters we have to address upon. We have to address the distress pattern of the patient, and we have to think what all clinical consideration that we can make. Next slide, please. So how we'll be applying this? First one, this is a commonly approved parameter by which we come to a conclusion, which is called as Bloom's taxonomy. So once we take history of the patient, remember what all important things that the patient has told. Like we had discussed earlier, the patient may sometimes be feeling depressed, sometimes be happy. So remember what all emotions that the patient has addressed. So words will have unknown meanings. Like for sometimes we'll tell it is easy. So how we'll tell easy? Sometimes it will take it's a cakewalk. Cakewalk is another metaphor for easy. Metaphor means what? We'll use colloquial terms, right? So just think. So what all patient has said, keep it in mind, and then try to understand what the patient has really meant. If you are having a doubt like what the patient has really meant, then ask the client what the patient has meant and then repeat it. For example, if a person is telling, I know that exercise is a cakewalk for me. So you can ask the client, what you mean by cakewalk? Like it, so the patient will be telling it is very easy. So you have to question the client what he meant by that, and then you have to reproduce it in his own terms. Like from your answer, I can understand that you consider exercise as a cakewalk, like it would be easy for you. So from taking the history, try to remember, then understand. Depending upon the patient's characteristics, we'll try to remodify, we'll try to apply our exercises. Once we are trying to apply, we'll try to analyze which all exercises are working, which are not working. Then we'll select the exercise that are working and we'll evaluate the effectiveness of those exercises. And at the end, we'll try to create an exercise. I feel like killing myself. So if you try to correct the patient, oh, it's bad, you should not be doing that, you should try to meet a psychiatrist. So I have always told that patient tries to defend their point, who tries to support their point. So you can change the perspective. You can ask the patient, if some of your friend had put a similar statement to your side, how would you be responding to that? So that's perspective shifting. Next is synthesizing from all the decision, all the information that patient has provided you. You can go for synthesizing. What do we mean by synthesizing? Like you are summarizing the findings that you have found and what the patient has found to the patient. Like you can say that from your term, I can understand that exercise is a cakewalk for you, and sometimes due to the pain you feel like killing yourself. Am I right? So that is what we mean by synthesizing. After taking all the history, you have to synthesize it and you have to convey it to the patient and check whether is it the same way that the patient has meant that we are reproducing it. That is some of the important questioning techniques. Next slide, please. So this is a common example, like how we are using perspective shifting. Most of our clients who are having back pain, they'll be very happy with the corset or the lumbar belt. At least we know that it's not such a good thing if we are using it for a longer period of time. It will decrease the tone of our trunk muscle. So this is a conversation between a patient and therapist. The patient is telling, I like wearing my corset, it helps to protect my back. The therapist is asking him, how does it help to protect your back? See the difference. Therapist is not telling the patient, no, you should not do that, it's very difficult. So the patient will tell, how no, I am using it, I am finding it helpful, I'll keep on using the corset. So therapist is asking, how does it help to protect your back? Patient is telling, it stops the back from moving too far, therapist. So the corset restricts the movement. Patient answers yes. Again, therapist asks, what do you think happened to the joint if your back are restricted? Patient replies, I don't know what happens. Therapist tells, well, if I put my wrist in a cast without anything wrong with it, what would happen? Patient replies, stiff. Therapist again asks, how do you think it would feel to get it moving? Patient replies, painful. So see, here you have made the patient answer the same thing that you wanted to say. So if you are telling the same thing, patient will be resistant, or patient will be highly defensive to his point. So this is what we mean by perspective shifting. You try to get your answer in reframing questions in such a way that patient tells the point that we want to convey them. So that will be more convincing to the patient. Next slide, please. Dealing with distress. As we all know, everyone has their own share of tragedies and bad lucks in life. No one is an exemption. So you can tell that you are acknowledging the patient's problem. I can understand that this is a difficult thing for you. I can understand, and you can ask whether you had opened up with this, with their difficulties to their uh, near or loved ones, or their any friends, or they had seeked any appropriate services. Like some people are very sensitive when we say, have you done a psychiatric consultation? They'll think that we are trying to label them in another manner. So you can reframe that. Have you tried to take any appropriate medical services for that? Then we can try to refocus them, like, what do you think I will be able to do to decrease your present concern? So by asking such a question, we'll get some important points. We'll try to refocus them back to the main problem that they are facing. So this is empathy. Distress is mainly nothing but empathy. See, a person is having arrow on his back, and the person is telling, I know exactly how it feels. See, the cat is trying to pluck the tail of the mouse. So if someone tells don't do, cat may not do. But that's perspective shifting. How would you like it if the mouse did that to you? So basically, what we are doing, we are listening, we are taking information from what the patient's mind is there, what the patient is directly saying, and then we are understanding what is the real problem. So when you are addressing empathy, you should know that you, after the session, you should cut that cord. What do you mean by cut that cord? There is something called as empathetic resonance. Empathy means you are acknowledging the patient's problem. What happens if a therapist, after his clinical session, is genuinely involved with the patient and genuinely think of the patient's problem? There is something called as empathetic resonance that is extremely dangerous and unhealthy for a patient, for a therapist's health. Because the patient's emotion you are getting involved with, the patient's problem you are getting deeply involved with, and you're keeping on thinking about the problem, it will face a toll on your health. So you should avoid something called as empathetic resonance, like applying too much of empathy. Even after the clinical session, the empathy should be terminated, because you have to address or attend so many patients, and you keeping this empathy with you for a longer period of time is also a bad idea. Next slide, please. Next slide. Sir, next slide, please. Not getting the next slide. After dealing with distress, so can you just play the next slide? Hello. Sir, the slide is after dealing with distress. Till dealing with distress we have done with. Can you, it would be helpful if you can play the next slide. I think some connection issues is there. So we have to start from slide number 41. We have finished till 40. Only few more slides left. 41 we have to. Hello?
Sir, I think the lab was host the meeting, therefore the meeting it can be
Bipin sir,
disturbed.
are you there?
Yeah, I'm there.
Hello?
I'm there, sir. I'm there. Hello, sir. Can you hear me? I think we have stopped till slide number 40. We have to start playing from slide number 41. Till 40 we have covered. Hello?
Hello.
I'm listening, sir. Please.
No, sir, is it possible for you to do a screen sharing from your laptop or something? Then it may work out.
Okay, let me check. Is it possible from my Android phone?
I don't think from your Android phone. If you have a laptop or something,
Okay, I have. I'll do that. 1
you
minute.
can do a screen
Give me
sharing
some.
from it. Yeah.
Yeah, sure. 1 minute.
Okay, I'm just, yes, my screen is on. Can you put it on share now?
So can you see the screen now?
1 minute.
Yes, it is visible. The screen is visible now.
Okay.
Visible? 1 minute. Composite regional center is presenting. I'm not seeing the screen.
Hope you can continue the session, sir.
Yeah. Is it audible?
Participants, is it audible?
Is it audible?
It's audible. It's audible.
Yeah.
It's audible.
Thank you. Yeah.
Okay.
Please go ahead,
so shall I continue? I have finished till 1 minute. I have finished. So I'll start with slide number 42. If you can put.
Is this one, sir?
Slide number 42. 1 minute. Yeah, explaining pain. The same way, same thing. What's the heading? Can you just tell me the heading? I'm actually not able to see the.
Yes, sir. Explaining.
Okay.
Pain.
So I'll continue. Okay. We have addressed the distress pattern of the patient. Now we are explaining how the pain is perceived. We are giving a brief idea regarding the neurophysiology of the body. Melsack and Wall's pain gate theory. A lot of changes in research has taken over after that study. We can tell the patient that there are so many receptors that are sensitive to the chemical impulse, temperature, and mechanical stimulus. And it's okay that the painful stimulus persists in a human body. But it's always we have to cut the unwanted impulses that the brain perceives for us to have a pain-limited activity so that person can do his day-to-day activities in life. Next slide, slide number 43, please. So basically, the human brain has to interpret the coming message and have to give a response. The human brain, if you know the brain, emotions are the food for the brain. So if you are feeding the brain with good emotions, it will give a good response. The brain will secrete endorphin and caffeine, which are the natural painkillers. Otherwise, the brain will secrete cortisol, which is a natural stress hormone. So basically, the brain has to interpret the incoming message. Next slide, please. Hello. Hello. Hello.
Yes, sir. We have changed the slides. Understanding pain.
Yeah. Okay. Yeah. There's some technical glitch here. Okay. One. Yeah. Understanding pain. So most often when the pain is perceived by the person, the important thing that they will be thinking is, first point is they will think that pain is disabling. Pain signifies harm. most important thing that the patient encounters will be, he'll be thinking that the pain is going to control his life and it will remain for lifelong. We can tell the patient that these all thinkings are abnormal, and the way the pain interferes in your life is entirely dependent upon the dynamics of the thought pattern and the inputs received by the brain. Next slide, please. Slide number 45. So the pain is rarely as simple as this. It involves so many thoughts and emotional contribution. As I have told, imagine that you had an unpleasant stimulus. Suppose in the garden you were stung by a bee. So next time, whenever you go to the garden, even though the bee is not there, first thing that comes to your mind is that at any time bee may come. I had got a painful stimulus from here. So this situation may create a painful response. So this same thing happens in rehabilitation. Whenever a person attempts a movement, if the patient had severe pain with that movement, you can tell that there are ways by which you can remodify the activity. Even though the original activity may be painful, you can remodify the activity in such a way that you can do your day-to-day activities with less pain. Next slide, please. What's in our cortex? So normally this is the representation your thumb is having, and tongue, eyes, nose. But what happens when a person is having pain? The painful portion occupies a major area, bypassing the other normal organs, and this creates a big problem, because if a person is having pain at a distant site, or not pain but any other stimulus in the distant site other than that of the painful site, person may perceive as pain because the motor by the pain stimulus or the painful part. Next slide, please. Slide number 47. Nervous system. Earlier I have discussed that receptors can become sensitive depending upon the feedback that we are giving. If a person is physically deconditioned, the muscles may become weak and it may exaggerate painful stimulus. So always we have to advise the person to take a baseline activity that he is comfortable with. Our brain always has a working memory, and this memory dictates the pain pattern. Person having a depressive mood, there are greater chances that the pain may persist for a longer period of time. Next slide, please. 48. So is it 48? Hello?
Working in a single laptop here.
Okay. I can just tell. Is it a diagram? Persistent lower back pain.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Okay. Thank you. So back pain and altered activity. Whenever a person is having back pain, the brain is receiving stimulus, sensitive nervous system, that pain is going to increase. Person will decide that I'll try to do less activities, and this reduced activity may result in muscle weakness, which may increase the pain. So this is a unhealthy cascade we have to break. So even if the patient is having pain with one type of physical activity, try to find out the variations by which we are addressing the same muscular nervous system pattern I had shown you. Person is given 3 choices, so he can opt for a choice that is very comfortable for him. Next slide, please. So what happens when a person is inactive? He'll be having weak muscles. So what's the solution? Strengthen. Stiff joints, we have to improve the flexibility. If a person is tired, try for activity pacing to preserve the energy. Relaxation. If a person is feeling fed up in life, most of the times I ask my clients, like, are there any person whom they feel uncomfortable with? Try to, are there any hobbies there that gives them happiness? For some it will be books, for some it will be music, for some it will be movies. So I tell to them that physiotherapists can only prescribe exercise and analyze your musculoskeletal problem. Your mental happiness is entirely dependent upon you. You have to find out what gives you happiness. And until and unless you find out that, you may not have a complete relief. It's not like you may not have, the amount of relief will be limited, because this is a factor that is affecting the pain. And once that factor is cleared, we can plan the exercise in an effective manner. If a client has put on weight, we have to devise strategies to lose weight. Next slide, please. This is sometimes.
Sir, excuse me.
Hello? Yeah.
Sir, excuse me. I
Yeah.
think you can pin that composite regional ID, sir, so that you can see the slides.
Yeah, sure. Actually,
Composite
I'm
regional
trying to
center.
composite regional center.
Yes. Just pin that one, sir. You can view the slides.
Even
Did you got it?
composite regional center I'm seeing here,
Yeah.
but I'm
Just
not
pin that one.
seeing
You'll be able to see.
composite regional center. Okay, so I'm getting it. It's a graph, right?
Yeah.
Overactivity, underactivity
Yeah.
cycle. Yeah.
Thank you.
So most of the times, when the person is having pain, what the patient will do, or the person will increase the activity level. Suppose a person who is mainly for housewives, what they will do.
Sir, I think Bipin sir is muted. Can you unmute?
Yeah. Can you hear me now? Hello? Hello? Hello, sir.
Audible,
Yes, sir.
audible.
Yeah,
audible.
okay. So this is the overactivity, underactivity cycle. What we experience in clinical practice is either the patient two extremes. Either they will go for complete bed rest, or either they will do increased activity. This can create a problem. Hyperactivity can increase the pain, and underactivity is to find out a baseline between high pain and low pain. We always advise the client to set tolerable for them. So that's the main thing that we have to address the client. That try for optimum activity that they can manage for a longer period of time. Next slide, please. They will pace it. What do we mean by pacing? Pace the patient's activity. So we can tell the patient to select that activity which they are comfortable with, and we can limit the overactivity. So how patient will do? Patient will prioritize. They will check among those that they need to attend quickly. They will plan how to do the activity. Then they will try to check out that what is the maximum activity they can do without severe pain, and then they will evaluate and select their responses. Next slide. So goal setting we had already discussed. SMART goals, they are specific, measurable, applicable, result oriented, and time. Next slide. Thoughts, feelings, and behavior. This also we had discussed in the beginning, like patient will have various thinking patterns, and these thinking patterns will affect our rehabilitation. If a patient is anxious or worried, frustrated or relaxed, these all things can affect their behavioral patterns. Next slide, please. Negative thoughts. These are some of the negative thoughts. Either the patient will do two extremes. Either the patient may not do activity, or the patient will complete the whole activity. Catastrophizing. For minimum error also, the patient will keep on thinking, and he will think that that's going to create a big problem. Should and must statements. Patient will think that they have to do than one activity of their house or their job. Otherwise, it's going to be very difficult. Next slide. Jumping to conclusion. Whenever a person is having back pain, he'll think mental filter is the thought patterns that contradicts the normal thinking. Some person's thinking may not be of any value. He will think that back pain, I'm going to be in bed. If I am remaining in bed for a longer period of time, I'm bedridden, and if I'm I lose my job. So that's a mental filter. Okay, so the thought pattern is not helpful. Next slide. So this is the thing that we can tell our patients to do. We can tell them to keep a thought diary. What all unhelpful thoughts they are having, they have to document it down. And then at the end of the day, they can analyze which of those thoughts were helpful to them and which of their thoughts were not helpful for them. So this way, the patient can effectively manage his the way of thinking and eliminate the negative thoughts that are not helpful in the rehabilitation regimen. Next slide. Thought challenging technique. So we can tell the client to name a situation. Like if a person was having back pain, what was the thought? I am going to be in bed for a longer period of time. Feeling, I was feeling helpless. Behavior, I went to bed and lay down on the bed for a longer period of time. So this way, person can channelize each of his thoughts, and he can analyze that where the fault has happened and how he can remodify the thoughts. And this way, we can channelize the negative thoughts to a positive way and help the person to avoid the negative thoughts. Next slide. Fear of movement, we had discussed before. The pain is there, patient will think different way, the person will think, and this thoughts will translate to feeling. This feeling will result in a different action, and this action will affect our rehabilitation program in a positive or negative manner. Next slide. Fear avoidance. Whenever a painful stimulus is present, the person will try to avoid the painful stimulus because he will feel that if he may encounter pain for a longer period of time, and this might be an illogical thinking. It's not what is needed is sub-maximal loading, like comfortable encountering of the painful stimulus rather than complete pain avoidance. Next slide. So in order to avoid this, we will tell the person to select a comfortable starting point that a patient is happy with, whether it is a painful stimulus or whether it is an exercise activity. Next slide. So relaxation techniques, we can teach the patient regarding breathing techniques. We can teach the patient regarding muscle relaxation technique. We can help the patient do visual imagery technique with the positive clues. Next slide. Hypervigilance cycle. So that the person who is having will be always concentrating the painful. Consider an example. A lion is very far away from the jungle, and you are in a protected area. But some of you may come any time. So even though there are other animals in the forest like deer, rabbit, butterfly, so what all are there in the hospital or in the forest, you will be thinking of the lion. So whenever any animal comes, you will feel it's a lion. So pain stimulus is also like that. Whenever you try to concentrate more on the pain, more on the painful stimulus, more it gets magnified. Just like a clock. You know, the clock has 60 seconds, but when we are concentrating on the clock, we can hear the tick sound of the clock 60 times. When we are not concentrating, we are not hearing the sound. So pain stimulus is also like that. The more we are trying to concentrate, more it gets magnified. Next slide, please. break the hypervigilance cycle. We can take the feedback from the possible solutions that they can tell, or we can practically tell that there are very rare chances that all stimulus may be painful. It is not necessary that before while they attempted doing one activity, pain was there. It's not essential that every time they will be encountering the pain. So by helpful thinking process, we can break the hypervigilance cycle. Next slide, please. Managing flare. Whenever a person is having a pain flare up, how we will manage it? We can convert it into good phase and bad phase. Whenever a person is having good phase, we can tell the person to be more active, and in the bad phase, we can tell the person to reduce their activity level, and they can take their own time, they can practice relaxation. So this is the way the patient manages flare up. They can manage the activity in a good phase also, bad phase also. So patient should be aware that they are in fully control of their pain, and the rehabilitation program is not going to hinder their activity in any way, and they will be the complete authority for their pain, and it's not going to keep them bedridden for a longer period of time. Next slide, please. So last one is like it's always said that we have to maintain a professional spirit in case of our clinical practice or patient practice or anything like that. So always we should give a feedback to the patient. We should try to add value to our practice by giving feedback and giving help to the patient. So why I emphasized New Zealand, because despite of their victory or defeat, they had always tried to be concerned for their opponents. So in this way also, for any client, we should be concerned. We cannot find solution for all the patient's problem. What we can do is we can work with the patient, like different patients will have different problems. So we can guide the patient and let the patient find his own way rather than we taking over there. So it's always better that we guide the patient and make the patient independent in his rehabilitation regimen. Next slide. I think we are coming to the end of the session. Next slide, please, sir. Okay. So it has been a privilege to share my knowledge to so many people. I thank you, all of you, for listening to me. So hope you all stay safe. Have a good day. Thank you.
Thank you, Bibin. Thank you for the wonderful question. Okay, now it's a question answer session.
Okay.
Participants, if you have any queries, you can put your questions, and we will be reading out the questions for Bibin sir. You can do the question, putting the question in the chat box, both in Google Meet as well as in YouTube live chat box too. Now I'll be handing over to Marimuthu.
Hello.
Hello.
So shall I start with the first question, sir?
Yeah, please.
Mr. Arun Balasubramaniam has asked about. Could you please tell about the kinesiophobia? Whether is it seen in acute or chronic LBP?
Kinesiophobia, as such, it depends mainly on the patient's fitness parameters. For example, this kinesiophobia, suppose in case of an old elderly woman who had a slip in the bathroom, like such, if the initial episode has resulted in significant pain and trauma, the patient will be obviously having instances of kinesiophobia. So we cannot clearly categorize whether it is for acute or chronic low back pain, but the fear of movement is commonly seen if the pain pattern persists, mainly in chronic low back pain patients. But the kinesiophobia can even be seen for an elderly patient. It can even be seen in the acute stage also. Yes.
The next question is from Mr. Biju Matapalli.
Yeah,
How do you identify patients who needs cognitive behavioral therapy?
Oh, that's a very tough question. How do you? First of all, I would like to emphasize that cognitive behavioral therapy. This session does not mean that we administer cognitive behavioral therapy. It's not meant that we should be administering it. We are just taking some patterns. Whenever we are taking the history of the patient, we will come to know whether the patient requires our assistance or the patient has to be cross-referred. Highly depressed patients, we are not supposed to carry on the therapeutic session without drawing a suitable individual. So most often, history taking, a proper history taking will help us in identifying whether the patient is a candidate for, I would not say cognitive behavioral therapy, it's a behavioral modification therapy we can do. Because cognitive behavioral therapy, as a practitioner, we are not supposed to administer for a chronic depressive patient. This is behavioral remodification therapy that we can give. We are addressing only that patterns which are directly affecting our rehabilitation setup, nothing else. Okay.
Okay, sir. Next question is from Ms. Aparna Rohra. Sir, how to
Yeah.
address a patient who is not becoming an active participant in therapy?
I would like to tell that actually that discussion was not included in this. There is a model called as trans-theoretical model. This trans-theoretical model has been devised, and it shows, like you, for anything, if a person is coming to a exercise session or anything, whether the person is ready for the change. This trans-theoretical model has got 4 phases: pre-contemplation, contemplation, preparation, and action. So in the third stage, like pre-contemplation, contemplation, preparation, in the preparatory stage only, like if when we are questioning the client, depending upon the answer of the client, we can understand whether the patient is ready for the session. So some of our physiotherapy clients might have come to the clinic knowing about physiotherapy. Other might have come on the reference of the practitioner or friends. Some might not be knowing anything about physiotherapy, and they have come as a last resort. So depending upon their mental parameter, we can decide the readiness. If she can check the trans-theoretical model in Google, it will give a better idea how to progress the clients. Actually, that was not a discussion topic in this. Trans-theoretical model as such is a entirely different topic which has to be discussed in detail. Yes.
Yes, sir. I don't know whether this is Baldev Negi. He or she has discussed something like cybernetics cycles of risk and protective factors.
Cybernetic cycles of risk and protective factors. Actually, even I have to, this term is cybernetics. Cybernetic cycles. I'm not aware of it. If I have to check out what that is. I'm not aware of that thing.
Okay. Next was from Himani CMC. How we assess the muscle is tense. How we assess that the muscle is tense.
See, the easy way by which we can assess the muscle is tensed or not is in common neurological scenario. What we'll do, we'll lift the muscle and do it. And by the way which the muscle is dropping down, we can check whether the muscle is flaccid, whether the muscle is spastic or normal tone. Whenever we are lifting a normal limb and dropping it down, there should be a momentary pause. If that momentary pause is absent, we can classify the pause is not there, but the time for which the limb has to come down is longer duration. We check as time. Otherwise, the best way to check is palpation, to check the temperature. That's the different way by which musculoskeletal and neurological evaluation assess the tone. She can also check by passive movements and check for the feel of the tone of muscle. These are some of the way by which we can check whether the muscle is tensed or not. Palpation techniques, passive movements, pick and lift and drop techniques mainly.
Just going for the basics. Sir, next question is from Arvind Bharatwat, sir. Is there any specific skill used for evaluate kinesiophobia? If so, please brief it.
Is there any specific?
Is there any specific scale used to evaluate kinesiophobia? If so, please brief it.
As such, I am not aware of a specific scale for kinesiophobia, even though we use Ashworth scale for grading spasticity and all the things. But for kinesiophobia, mainly the history representation of the patient can help us in finding where the patient is. As such, I am not aware of a scale used for evaluating kinesiophobia as such.
Okay, sir. Next is from Mr. Alok Sahu. Techniques is most effective towards low back pain as well as to reduce psychogenic stress.
Actually, the mental imagery, we had an audio clipping, but due to the technical glitches and all the things, I was not able to take. What you can do is, if you can check mindful meditation in internet, you will get a lot of short clips. What we do is guided imagery. Guided imagery techniques helps a person like to imagine. All the techniques have been emphasized in such a way that the patient can vent off his tensions. So what we'll be doing is we'll be telling the person to close his eyes, and we'll be playing the mental imagery clip. And this mental imagery visual meditation technique has been helpful in reducing the patient's tension. So what he has to do, he has to check for mindful meditation clips for 5 minutes. It's available in a website called as Future Learn, where the courses are relatively free to attend. And if there he can check for mindful meditation techniques, he will be able to download the slides, and those slides will be really helpful.
And next question is from Shanmuga Priya. Back pain due to carcinoma from other orthopedic conditions.
Oh, see, regarding carcinoma, the main clinical picture that we are getting is unexplained and abnormal weight loss. Suppose if a person is coming with back pain and person is telling that I have lost my weight, and when you are checking, there are no history of diet regulation, no history of physical activity. The patient has had a sudden weight loss. Patient had a history of fluctuating temperature. When we take a proper history, this should give us a guideline that this patient should be referred. So in carcinogenic pain also, there may not be any specific aggravating or relieving factor. For every position, the patient may be complaining pain. So history taking, if you are strong in your basic history taking, you will be able to catch whether the client requests cross referral or whether the client is not amenable to physiotherapy. So carcinogenic pain and all, proper history taking is the main key. Yes.
And Mr. Arun Balasubramaniam has added to your points that like Tampa scale of kinesiophobia is the common scale.
Yeah, thank you for giving me that knowledge also. I learned this today. I was not aware of it. So I'm thankful to Mr. Arun Balasubramaniam, Tampa scale of kinesiophobia. Thank you for giving me that knowledge.
And next is from Mr. Arjun Tarun. Sir, may I know your view on solution-focused therapy and LBA?
Solution-focused therapy on LBA. See, solution-focused therapy, actually, in our cognitive behavioral skill, solution focus, I strictly feel that it's not the domain of physiotherapists. We can help the patient in finding we are helping the patient devise strategies to find solution. So it's up to the patient to find solution. Okay, so therapists should not provide solution to the patient. We are helping the patient, saying that there are so many ways by which you can try to minimize the pain, and let the patient decide what solution he wants from this. So solution focus is entirely dependent to patient. We are trying to derive the strategies by which he can adopt for a good solution.
Okay, sir. Next is from Ms. Divya Babu. Sir, yeah. Cryotherapy or EAT modality, which is best for painful spasm?
Actually, in my clinical setup, even for CR patients also, we tell one thing, that you palpate the muscle. If muscle is hot, go for cold. If the muscle is cold, go for hot. Normally, for edema relief, we go for icing, and for flexibility, hot modality has been given. But commonly, it has been said that the palpation temperature should be a guiding factor. and external temperature also. If the muscle you are palpating is hot, go for a cold, and if the muscle you are palpating is cold, it should be warm. Yes.
And I think questions are over. Is there any
Yeah.
other questions from the participant side? Please post your questions here. And I also request Ms. Fatima Sumaya, our physiotherapist, to share the questions which are in the YouTube. Ms. Fatima Sumaya, are you there? Any questions from YouTube? We are checking the questions from YouTube.
Yeah, no problem, sir.
I think questions are over.
Hello.
I think we are not having any questions from YouTube also. We cross-check.
Okay, sir.
I'm handing over to Mr. Binoy Matthew, sir.
Okay.
Hello, sorry for the technical glitches in between. Um, Sumaya, are you audible? Hello, Sumaya. Okay. So I would like to use this opportunity to thank Dr. Bibin, who had taken a wonderful class and who had enlightened us by taking us through various facets of behavioral skills in treating low back pain. And on behalf of CRC Core Code and especially the Department of Physiotherapy and from all the participants, I would like to give a heartfelt thanks to Dr. Bibin for sharing his expertise and inputs. And to all participants, we are looking forward to meet you all in the future webinars too. We'll be adding feedback links in both the platforms. Already in YouTube, we have already posted. We will be immediately posting it in the Google Meet also, and looking forward to meet you all in future webinars. And we are signing off. And stay home, stay safe.
Audio.